Hello, everyone. Welcome to another webinar from Steps Forward Innovation Academy. Today is the second in a five-part series this year focused on value-based care. Today's topic is practical steps for aligning payment and value-based care. And over the next 45 minutes, we will discuss opportunities and best practices for key domains within underlying payment methods, specifically patient attribution, benchmarking, and risk adjustment. Please note, this webinar is for informational purposes only and is believed to be the current and accurate at the time of the posting. Please consult a professional advisor's specific medical, legal, financial, or other advice. References and links to third parties do not constitute endorsement or warranty by the AMA. As mentioned, we'll be focusing our discussion on the current landscape for three domains within underlying payment methods for value-based care arrangements, specifically patient attribution, benchmarking, and risk adjustments. We'll explore associated challenges and proven strategies that can help overcome them. Today, I'm joined by Drs. Jerry Finkel and Stephen Perotti. Dr. Finkel serves as the Senior Vice President, Chief Medical Officer of Value-Based Enterprise and Chief Primary Health Officer at Henry Ford Health. He provides executive leadership across the clinical enterprise over the strategy, design, and oversight for the enhancements of value-based outcomes. He also leads primary care services across the organization, as well as the ACO, physician networks, and clinically integrated networks. Dr. Perotti serves as the Executive Vice President at the Permanente Medical Group. He is responsible for external affairs, corporate development and patient safety, risk management, and employer and group customer relations. He also serves as the vice chair for the AMA's Integrated Physician Practice Section Governing Council. Just as a brief overview for today, we're going to be running through some key elements from our Future of Value playbook, specifically our payment playbook. And this was developed in collaboration with AHIP and the National Association of ACOs to advance voluntary adoption for value-based care arrangements, specifically focusing on finding alignment to help ease participation for creating an appropriate foundation for alignment for those participating in these models. Specifically, we really were trying to focus on participating practices, health plans, and VBC entities to ensure that we have best practices that are formed by real-world experiences in order to help inform both current and future design of these models. So in development of these playbooks, we specifically focused on one, creating an advisory group comprised of members of each of our associations. We also had a managing committee of association leaders, which was buttressed by literature review, environmental scans, and interviews with other subject matter experts in the value-based care space. We were specifically cognizant of selecting work group members and experts that were diverse in representation, both in terms of national and regional health plans, large, small, rural, integrated, and independent practices, as well as VBC entities like ACOs that were both far along on their value-based care journey, but also those that were a little bit newer to participating in these types of arrangements. In the slides afterwards, we also have a full list of the work group members that participated in the development of this playbook. Within the playbook, we identified 7 domains that really underscore these underlying payment methodologies. We're going to be spending our time today specifically focused on the first 3. So as we talked about, patient attribution, benchmarking, and risk adjustment. We'll have a separate webinar in July that will focus on the latter 4 domains. Before we get into each of these domains, really wanted to underscore some common themes that the work group identified across those domains. The first of which was the importance of collaboration and flexibility. Not surprisingly, everybody agreed that is really critical for all the value-based care entities participating. So both on the physician practice side, VBC entity side, as well as on the plan side, to really come together to really find ways to collaborate, to identify the appropriate methodologies to apply, taking into account key differences in readiness, capabilities, the key needs of patient populations that really need to be taken into play. The other part was really underscoring the clear need for transparency, particularly around documentation and feedback around these methodologies and performance throughout the performance period, given the potential complexities of some of these arrangements, that transparency was critical to ensure that trust remained once that collaboration had been established. The group also recognized the importance and differences specifically around rural geographies, that they really require different approaches to being able to participate in creating these methodologies that really works best for those geographies. And then the other part is the need for better alignment. And we'll hear some of this as we go through some of the domains. It really is a huge burden on those participating in these arrangements when they have to do some of these things in 5, 7, 10, 15 different ways. It's really important where feasible to really create more alignment across these different payer arrangements, keeping in mind the need to still remain flexible when it comes to these efforts. All right, now we're going to get into a little of the nitty gritty. I'll pass it over to Dr. Finkel as we get into some of these domains.
Yeah, thank you so much, Chris. And I will tell you, I found the playbook to be just a wealth of information. As everybody knows, value-based care, and more importantly, value-based contracting requires a high level of understanding of your population and of your organization. And it's a great way to get yourself in trouble right away. So I'm certainly interested in hearing the insights of those of you that are listening, as well as Dr. Perotti, because they're so rich and insightful. We're going to take these first three as three of the levers, and as you all know, value-based contracting is much more complicated in many ways than fee-for-service. You have to understand your population in a very different way. And the three things that we're going to start with are attribution, benchmarking, and risk adjustment. And each of these, in a sense, in its own right, has a certain level of risk depending on what the model is for each of them, how you decide to do attribution, what are you using for your benchmarking, and how are you managing risk adjustment. And so we'll be doing these and getting into these each one by one as three of the many different aspects that have to be managed and understood in negotiating as you get into and succeed in value-based reimbursement models. Steve, I think what we're going to do, so the format, I think, is going to be very conversational. Steve and I will, I think, go back and forth with respect to comments on some specific slides, and then give Chris a chance to really be able to showcase some of the playbook content as well on each of these various different specific areas: attribution, benchmarking, and risk adjustment.
Yeah, and Jerry, I think that's a great point. And you know, when you think about these, I mean, even though we're artificially going to be talking about them as separate pieces of a value-based arrangement, they actually go hand in hand. So you have to have basically an understanding of each one of these and how they intersect with each other. The other piece here is, you rightly sort of referenced, that a physician practice has to be on top of understanding the nuts and bolts of what you're negotiating with each one of these. Then you have to have a modicum of trust with your payer, and figuring that out. And then there's also a balance between, you know, how much resourcing can you put into this, and how many different arrangements can you juggle at a given time. There has to be enough of sort of an upside arrangement to justify it. So we'll get into that as we dive into this.
Yeah, and I think we'll hear a lot of allusions to the need for data sharing, data access, timely, what's included, right? And so we also have a separate playbook that talks a lot about those best practices that underpin a lot of the ability to actually succeed in some of these best practices as well. And we'll be covering that in a later webinar in the later part of the year. So wanting to make sure folks are aware of that as well. Great.
Yeah, thank you, Chris. One of the slides towards the end will show you just how many different combinations, even with just these three considerations, you might enter into. And so I think to Dr. Perotti's point, very, very well taken, that it's likely that you might create, as we have, a playbook of your own, where you essentially have expertise in particular models, and you may want to then make sure that your partnership with your payers addresses the areas that you have expertise in.
Yep, I think that's a great point that, I think we have across the two playbooks over 90 best practices, and I don't think the expectation is everybody would do all 90. Picking and choosing what makes sense based on some of these criteria to allow for long-term success is really what's going to be most important for your organizations, your payer, your market, and obviously what your population needs specifically are. Patient attribution, Dr. Finkel.
Yeah, and thank you. This is really just a simple visual that gives you an idea of what's at risk here when you try to manage a population. And so this just shows you that for both commercial, the left two columns, and Medicare Advantage, the right two columns, even in the first year, you're going to lose 20%. This is just an average, 20% of the population that you started with. And in 5 years, you have almost nobody left. You've lost the majority in many cases of your population. With Medicare Advantage, not quite as dramatic, but still pretty significant. And so as you think about how you want to contract, whether prospectively or retrospectively, there are pros and cons to both. This was just giving you an idea of the fact that you may spend a lot of time managing that 20% of patients that don't end up in the group that essentially determines your payout. And the same thing could happen in a retrospective payment model. And I thought we would maybe showcase some examples that we've had. I'll let Dr. Perotti comment, and then maybe we can talk a little bit about some of our personal experience, and then hand it back to Chris for a bit of a sum.
Yeah, Jerry, I mean, I think what this slide's illustrative is that you need to take into account when you're negotiating with your payer plan, the fact that there is going to be turnover, and actually having some historical context in specific, because again, this is sort of perhaps an average. There are different plans that have higher turnover or lower turnover rates. And so being able to build that into whatever model from a payment perspective is important. There's a couple of pieces underneath this that I want to highlight. So number one is like, okay, let's say you have an agreement on a general patient population that you're going to be attributably responsible for. That one of the questions is, how do you do that? So there's not just the patient turnover, there's also turnover within the practice. So you've got to make sure that you've got agreement with your payer on the list of providers that are going to be attributable for the primary care of these patients. So what does that look like? So there's the physicians there. You've got to make sure that if you're going to have APPs involved with providing care, they're included in that list. There become sort of other sort of discussions here in terms of specific patient populations. So depending on the way your practice is set up, you may have patients that are seeing specialists as primary care clinicians. For example, you may have a specific program for heart failure where the cardiologist is the primary care provider. You've got to have a pre-existing agreement with your payer if you want to have attribution to that specific set of specialists. And I could name any number of different specialties where that could be applicable, whether you're thinking about oncology or infectious disease or others. There's sort of another piece here, which is the question of like patient selection. So what list are you using? Or are you allowing patients to voluntarily attribute to your practice? And again, there are pros and cons to that. Some of that relates to the level of stability and turnover in the patient population. So having that historical data to be able to speak to it is important. The other piece I'll just sort of speak to is that, sometimes we artificially talk about prospective versus retrospective attribution. There are methods of being able to rebaseline or have another discussion in the course of a given year if there is a particular event or issue where there is significant patient turnover, right? And we recently went through a massive, pandemic and, crisis. So, having pre-existing arrangements with the payer to say, if there is an event we need to be able to have a discussion, mid-year to rediscuss attribution because the previous methodology that we had agreed at the start of the contract is no longer applicable. So there's a lot that goes into this. It's ironic, Chris, because when we first had the initial discussions, with NACOS and AHIP, everyone thought, okay, this is going to be a relatively simple subject, and it being one of the most complex ones. What do you think?
Yeah, my favorite quote coming out of that was, "I can't believe we just spent 3 hours talking about attribution." I think everybody came in, seemed like it was pretty straightforward and realized it's not. I think the other piece of it from the group was there wasn't one method versus another that ultimately came on top, right? I think it's looking at some of these pros and cons for these methods and figuring out what works best for you, given your populations, geographies, et cetera, given there are some differences depending on which methodology is being used.
Yeah, and I would just to add, I had great comments. I think to add to some of those with some of our own particular experiences, I think that one of the biggest challenges we have is reconciling who's actually attributed based on what the payer thinks and based on who the providers are managing. And we've actually had contracts where there is as much as a 40% discrepancy where we are thinking we're managing, I'm just going to use a number, 100 patients, and the payer is giving us 60. And of course, if you're getting paid PMPMs or other things like that, it can really dramatically impact. So we literally have to have a team of individuals that their whole job is to reconcile our payer attribution rosters with our own sort of Epic attribution rosters, so that we know that, and the payers know, and we can do this collaboratively, that we're both managing the same population that we're being evaluated based on. And that sounds a lot easier than it is to do, frankly. And it happens on a monthly basis, and it changes on a regular basis. And so to Steve's point, I think very, very important. The other thing, especially if you're going to be doing sort of retrospective, is if you get somebody who is, there for only the last month and then now is on your roster, you want to make sure that there's carve-outs, like quality carve-outs and so forth. And I'll give you just one other example. We have a direct-to-employer contract where patients can be assigned to us in two different ways. One is they can select a product that says, this is the group that I want to be managed by because I like this particular product, or I like that network. But the other way is that even with the patient not realizing it, in a sense, they can be attributed to us by the predominance of care that they've received being from one of our providers. And it's really important to understand the difference, because what you've done in what I would call the attributed model is you've created adverse selection, because you're only going to end up with patients attributed to you who has sought and received a significant amount of care. And so our targets for a population that selects us versus a population that is attributed to us is very, very different between those two populations. And if you were to combine them, it would be very challenging, and it would be maybe more dependent, your performance, on what percentage of those patients actually selected you versus the kind of quality and outcomes in the care that you're receiving. So really understanding the process and the model. And to Chris's point, that's why you can spend a lot of time talking about it, because there are so many nuances to attribution, as simple as it sounds, which is who's my patient and who is not. There are so many things that can determine that, and that can determine how you might be judged, or I would say rewarded for the value that you've created in that population.
Yeah. Absolutely. I think that, again, that transparency and collaboration upfront is going to be important. But as you noted, Dr. Finkel, that's a process that happens throughout the performance period as well. So that has to continue. It's just not a one-time activity, which is a really important part of success. This is just going to be, I believe, just a brief overview of the key goals of attribution. I think we heard this a lot. Ultimately, the goal really is just to accurately identify the population that the entity or participating practice is being held accountable for during a specific performance period. Again, also have to have understanding of what that performance period is. Often those are 12 months, but that can be a different time period, so really understanding that component. I think the other piece is really wanting to honor the patient's preference wherever possible as part of who they want their attributing provider to be. And then being able to ensure that there is a reasonable ability for that attributed entity to actually coordinate and improve their care, which, Dr. Finkel and we have a best practice on this as well, right? If they get attributed later on in the year, there really isn't the ability to improve care because it's happened so late in that performance period. I think we heard a little bit of some of these challenges. One is accuracy. So really wanting to make sure that you're aligning and not having missing or inaccurate or delayed data when it comes to these attribution models. As was noted as well, ensuring that there's the correct identification of who is the accountable entity that is ultimately overseeing their care. And then between these models, there are differences between accuracy and predictability, between prospective and retrospective. Prospective tends to be more predictable. Retrospective tends to be more accurate. But there are some blended methodologies as well that can take some of those into account. So if we go into the next slide, I'm not going to go through all of these best practices, but I know that there were allusions to many of these things. Again, one of the aspects is multi-year attribution, making sure that there's a core set of data to limit differences between some of those changes from year to year. I think we also heard, the potential inclusion of advanced practice providers, but also key strategies in terms of identifying the appropriate clinician based on attributed entities that may not be primary care and focus over specific periods of time. So really thinking through who are the right folks, taking into account claims, patient selection, preferences. All those aspects are really important to take into account and manage throughout the year. So, I don't know, Dr. Finkel or Parodi, if there's anything you all wanted to underscore there. I think you all alluded to many of these best practices that are mentioned here.
I think it'd be good to get to the benchmarking.
Great.
Yeah.
Let's move on to the next section, which is benchmarking.
Yeah, so again, wanted to just present a simple visual on just how difficult it is, number one, to benchmark. So in particular, if you're going to try to create prospective benchmarking, in other words, I'm going to try to anticipate what the medical spend will be next year in this year's contract, you can see how difficult it might be. And this is our employee health plan. This is our actual data for our employee health plan from year to year. And you can see that if you made a deal that said, we're going to get a 6% increase per year, there are years where you would do fantastic and years where you might not. And it's not necessarily based, especially if you did something like in one of our contracts, we did a 5-year agreement with prospective payments for 5 years. And of course, there's so much you can't anticipate. At the same time, if you're doing a retrospective sort of look back at benchmarking, you also have to be careful because in a year where there's like 2022, where there's very little increase in costs, then you could actually have performed what you might have thought was quite well and end up actually owing money back. And so this just gives you an example. And one of the things that we certainly all know and have spent a lot of time talking about is pharmacy costs. And there's so much, especially if your contract includes pharmacy costs with the GLP-1s and so forth. We've just had our first patient with who's going to get gene therapy, which is about $1 million cost. And so these kinds of things are not always you can't always anticipate them, yet they can add to a significant amount to the kinds of things that will impact your outcomes if you've done various types of benchmarking. And we'll give additional examples. I'll hand it to Steve to share his thoughts as well.
Yeah, no, I think, to make this as simple as possible, I mean, essentially think of it as an O to E, when you're thinking about benchmarking. So, what's the observed cost versus what were the expected costs? And so then the debate becomes what we believe the expected costs are going to be. And you can see, Jerry, with what you're displaying, and I think what others have experienced is the incredible volatility that we're experiencing in the healthcare market today. It makes it hard, whether you're a payer, whether you're a physician practice, to actually predict this. So it's important that you do use multiple years of data to try and at least smooth out some of this volatility. There's also sort of the question of, having some stop loss gaps, either at the high end or low end in terms of the amount of upside or downside risk that either entity, whether it's the payer or the physician practice, is taking. And understanding that there's probably going to be a need for negotiation of a corridor between the two to adjust for that. Which means, in the good years, you're limiting your upside, like you were talking about, Jerry, but on the bad years, you limit or minimize the downside to the physician practice. And to be honest with you, in the conversations we had with the payers that were part of the group that participated in the development of this playbook, they're cognizant of that. They're cognizant of the fact that, the physician practices do need to remain viable in those down years. The other piece here that I'm going to speak to is that it is very hard to predict utilization just year over year. And I think it is very hard now in this context with the aging population, where expected medical costs are going to go. So I think you need to build that uncertainty into those negotiations and probably anticipate that utilization is going to go up, and to be able to speak to that, particularly in specialty care. One of the things that you brought up, Jerry, is really important, and you've got it displayed on the slide here, is pharmaceutical costs, which I think are wholly and incredibly unpredictable. And so are there exclusions that need to be built in to the contract that you're negotiating? I would suggest probably yes for some of these that, are extremely expensive. Others maybe not. Maybe GLP-1, there is a way to, from pop health perspective, manage that. And if you feel like you've got that built into your practice, being able to build in what that looks like from a benchmarking perspective, if you've got a handle on how many patients are going to qualify for those medications, how many qualify for alternative therapies, and are you willing to go at risk for that? So those are really, so the reason I bring this up is that, with our group, we're often talking about what do we think we can clinically pull off in a given year for a given set of conditions. Do we think that's a reasonable benchmark that we think we can hit? And then we negotiate that. So those, you really have to actually understand your practice. So you need to understand your population. You need to have the data to understand the population, and then a good analytic group or someone that's assisting you or consulting with the analytics to predict where you think you can get in a given year.
Yeah, it's so important, Steve, to be able to understand. And I will tell you that we've learned some things the hard way, and so I'll share some of that. And one of them is, are you going to be judged based on your historical trends, if you're going to be judged on trends, or some sort of regional or other trend? Because what we've learned is sometimes in the area that we're in, we may have a cost trend that's very, very different than what the regional trend is. And if we're being judged by the regional trend by that specific payer, we're going to be in real trouble. And you might say, well, risk adjustment can help with that. And I'll just bring up one thing that I think is really important. And that is, what we've learned is that risk adjustment helps you with the burden of illness, but it doesn't really help you with the prevalence of illness. So what we found is that we have twice as many diabetics in our region, in our area that we manage. And I'll just use the example of the HCC code that gives you a 0.3 for diabetes doesn't cover the cost of the GLP-1s. And so if for whatever reason you have a lot of diabetics, your risk coding won't really adjust for the cost of care that you should anticipate. And in another region that doesn't have a prevalence of disease, which may not be a disease of high severity, but it's a disease that costs a lot to manage, they may reap the benefits of being in a region that just didn't have a high cost trend. So we sort of learned that a bit the hard way. The other thing that I think we're learning is that we had a direct to employer agreement where over the course of several years, we found that our cost of care was significantly less than what was a matched cohort within that same payer, within that same employer. And So if you're being judged by trend only, you could actually be well below the cost of care of a sort of age and sex and risk adjusted, prevalence adjusted match trend, and not be getting credit for the fact that you might be $40 PMPM less because your trend was less, and find yourself owing money back in spite of the fact that you're actually providing results. So making sure that you're getting credit for the delta between the outcomes, both financial and clinical, that you're providing for that specific population, not just the trending, because then you're, I think, playing the game against yourself every year, not just against what would be the benchmark. So understanding what you're being benchmarked against has for us been really important. And then my last point, and I'll hand it back, is just making sure that we're understanding what's included, because there's a lot of non-claims medical expense that can that may impact in some ways your cost of care, and it may or may not be something that you have a lot of control and or input into. And so just being aware, and these are not negative things, as long as you're aware of them and as long as you consider them, take them into account, they can be very positive. But just again goes to show you that in something that appears to be fairly simple, like benchmarking, there are a lot of nuances, and the importance of being able to understand your population, to Steve's point, very, very well, and to be able to understand medical trends are very, very important to be able to draw up a contract that allows you and your payers, frankly, to achieve great outcomes and to realize the benefits of those outcomes.
You know,
Fantastic.
you brought up such an important point here, which is understanding like your own market, where you fall within that market. So how big are you? So, you know, depending on the size and scale of, let's say, a patient population that you're responsible for, you know, it may not make sense to benchmark to just local trends or regional trends, particularly if you're a large enough entity. You may be ending up benchmarking yourself, which is a problem. So there really needs to be some thought put into, you know, does it make sense to benchmark nationally versus regionally versus locally? And again, that it may depend on the particular part of the country you're in. Are you a rural practice? Are you, you know, an urban, you know, sub-regional practice? So there are all those sorts of things that you've got to take into account.
Absolutely. And I think Dr. Finkel, you know, I think your comments underscore the importance of these these domains aren't individualized. I think Dr. Perotti, you mentioned this at the beginning as well, right? It's aligning some of these strategies across the board because they do have an important play across them and within them. So I appreciate that, underscoring that element. Want to move us along real quick. If we can move on to the next slide very briefly. This is just, you know, summarizing, you know, the key elements of benchmarking, you know, really wanting to make sure you're establishing an agreed upon, underscoring agreed upon cost target that incentivizes these transformations, making sure there's an appropriate ability to actually achieve these efficiencies and these goals that are set out and agreed upon up front, and making sure that the ability to reach these targets are predictable, accurate, and obviously transparently set. I think some of the challenges you all mentioned, you know, just the inherent difficulties of being able to estimate costs that would have been there if these types of arrangements didn't exist. That's a very difficult thing to identify. Also really wanting to make sure to understand the sustainability business case in order to do this. This does take a lot of time, resources, investment to be able to do this appropriately. And that's not an equal playing field across the board, depending on practice settings. And then lastly, you know, making sure that keeping in mind benchmarking solely on historical costs and the kind of quote unquote ratcheting effect. If you're only competing against your past performance, it's really hard to get rewarded for doing good work if you're only expected to just do better as your past self performed. So next slide, I'm not going to kind of go through a lot of these things. Folks can review them. I think a lot of these components were identified, using multiple years, et cetera. I think there are a lot of great aspects that people can look in and figure out what works best for them. So let's move on to risk adjustment.
Yeah, and if you go to the next slide, I think what you'll find is there's a theme here, right? There are intrinsic challenges with each of these different areas and the remaining 4 that exist within the playbook. And this is one of the areas where there's, I would say this is an attempt, risk adjustment, to be able to normalize the cost to provide care to a particular population. But the Society of Actuaries did this assessment. And what's interesting is that HCCs, which is the thing that we're all very, very familiar with from Medicare Advantage, has a correlation of 41%, which means that the likelihood, even with good HCC coding, that you are going to be able to anticipate the future costs of the population you serve is still very limited. And I think that that's really the point here, is that no matter what you do, like there are unknowns. And I think making sure that you have a great payer partner and that you have a good relationship with that payer so that you can work through those things. It's not just, oh, well, this happened, and I think is going to be really, really important. And this also gets to the other point that I made, which is this is an attempt to try to evaluate the burden of illness. It doesn't really account for prevalence in the same way as it does for severity, but nevertheless, still remains a challenge. So I think that making sure that you do this accurately is really, really critical. And we spend a lot of time talking about how best to do that. But even then, there are some challenges in being able to anticipate the future costs for a particular population. The last comment I'll make to hand to Steve is that here's where scale matters. Obviously, because if you can manage a larger population, I think that just mathematically you'll have less variation, and that allows you to have more predictability. In many ways, maybe better predictability than what might be gleaned from sometimes from risk scoring.
Jerry, I really appreciate the data that this slide's showing, because it shows how not helpful HCC is actually ultimately when it comes to actually predicting from a risk adjustment perspective the burden of disease in a population. And I saw the comment in the chat there about physician burnout, and there is a bunch of burnout related to having to code and try to code accurately in the coding game, if you will. So one of the big debates, I think, and one of the opportunities when you're negotiating these contracts is to simplify the risk adjustment model. And I might be a little controversial here, but some of it just comes down to basic demographics. What's the age of the population? What's the institutional status of the population? Is a bunch of the population disabled? There's some key areas that you can focus on, and maybe a few substantiated conditions that you might focus on, particularly depending on what you're going to base the value-based arrangement on. So there are opportunities to simplify risk adjustment depending on what you want to negotiate with the payer. And again, I would encourage folks to get consultation and help with that. And there is opportunity, since we're on an AMA webcast, for the AMA to advocate around risk adjustment, particularly with government payers, because often the commercial payers follow what the government payers, particularly Medicare Advantage, is doing. Because from the standpoint of actually a physician practice, ideally you would prefer to not have multiple risk adjustment models with all your different payers. It would be nice for some standardization around this. So I would say that there's opportunity to influence here when it comes to basic demographics, picking a few clear conditions, and then settling on that. Given that, using something complex like V28, which is what the current Medicare Advantage model is, you can see how accurate it is. So I think there's, a need for us as physician groups to be both savvy with this and negotiate more specificity.
Yeah, so that was one of the things in the multi-payer alignment from the playbook that identified risk adjustment as one of the key areas for better multi-payer alignment to remove that barrier on many practices that are trying to navigate so many different, sometimes proprietary models that are being applied.
Yeah, I would just double down on what Steve said. I think that it's critical. So yeah, I can just tell you in our clinically integrated network, we have, to answer the question, Connie's question as well. We have a clinical, integration program that has all of the metrics and so forth. And we use this for all of our payers. It has made a dramatic difference so that there is one set of measures for all of the payers and one set of methodologies. So providers get incentivized for all of the patients they see in the same way. So I don't know that that's possible to do in all areas, and it may require that physicians partner with each other or gain scale in order to be able to have the ability to drive what is true performance, and then how do we help the payers to adopt that so that we can really focus not on 11 different products and the different measures that we're being judged on, but on true great outcomes for our patients that we all want anyways, and being rewarded for that through every contract we sign. So, and that sounds like, wow, that's amazing, and it should be standard. And so I love the idea that there's opportunity to advocate for consistency across all the payers around what does a good outcome look like, and that's what we should be striving for as providers.
Absolutely. So I know we're running short on time and want to make sure that we have a chance to hear from our audience members. For those that are still on, if you could please use the Q&A chat to be able to submit any questions. I know we have a few questions that were already submitted ahead of time. One of them, just to start out with, I know Dr. Perotti, you mentioned this briefly, right? I think there is the perception, right, the promise of value-based care, right, to better align some of these incentives and make it better aligned with outcomes, but also the potential perception, and we've gone through a lot of best practices of burden to be able to do this successfully. How do you, especially for smaller practices, navigate some of these complexities to make it sustainable rather than just a different set of burdens that are being put on physicians in their practices?
So I think there's a few choices to think through. So number one, it's got to be enough of a scale with the number of patients that your practice is providing for to make it worthwhile to invest, because you're going to have to invest time, analytics, and some resources to negotiate the contract and maintain the contract with the payer. So it's got to be enough patients to make a demonstrable difference. And I think that, what Jerry was saying earlier is really important here. It's got to be explainable to the physicians in the practice that this is the right thing to do. You're going to see better outcomes. And when I say better outcomes, it's better outcomes from a patient-facing perspective, physician workflow perspective, because ideally you get more alignment with the way we're practicing, and then hopefully a financial upside as well. So you have to have all those pieces in place for this to make sense. And you have to have consensus amongst your group that this is the direction you want to go in.
Absolutely. And I know that's one of the other domains in terms of that kind of education piece that we'll be covering in our later webinar. Dr. Finkel.
Yeah, I love, I always do love Steve's perspective. And I think, when I think about what physicians need to do value-based care right, I think about what I call the 4 C's. And if you're not in a group that's large enough, and it doesn't matter how it's large enough, it could be through an ACO or through an IPA or through a PO, or just your medical group is large enough or whatever. But I think the idea that physicians need to come together in order to be able to really drive care. And the 4 C's are, number one, capital. So there's investment that's required for value-based care, as Steve said, for analytics and for other things. Number 2 is capabilities. It's hard to find, and you need to sometimes partner with payers to invest in care management, to invest in team-based care or community health workers or, SDOH solutions or whatever the case may be. But you have to be able to provide those capabilities. Number three is contracting, and we've been talking about that, and you see how complex that is. And it requires a level of sophistication that doesn't exist in an independent practice. And so that has to happen for us to be successful. And the four, of course, is compensation, because at the end of the day, physicians ought to be able to receive some of the value that they're creating in driving great outcomes. And if you're not in an organization that can provide the 4 C's, you probably need to look at partnering with other physician entities or enterprises that can get you to a point where you're able to do that, and or partner with payers that can allow you to be able to do that. If you're missing one of those, you may have some challenges, because value-based care is not an easy game for a small population.
Absolutely. And I think, for those that may have seen it, CMMI released their strategy and really wanting to allow the ability for some of those folks in more independent practice settings to have the opportunity to sustainably participate in some of these kind of arrangements. Do you all feel like participation in ACOs, the CIN, IPA, some of these other structures is a sustainable pathway for smaller independent practices to potentially participate in these arrangements, or other ways that can make sure that this is available across practice settings?
Want to start, Jerry?
Yeah,
Since
I
you
think
have
it's
the direct experience.
I think it's critical,
Yeah.
to have a critical mass if you want to engage in value-based reimbursement. I think everybody should be providing value-based care. It doesn't matter whether you're a solo practitioner or you're in a group of 6,000 physicians. It doesn't matter if you're a payer or a provider or an employer. The idea that we should be providing high-value care is a given. We shouldn't tolerate low-value care, no matter what the reimbursement model is. But if you want to move into reimbursement models that allow you to take on risk, and as a result, realize some of those rewards, I do think you need to be in a large enough group, however you get there, whether it's an ACO or an IPA, to be able to provide those 4 C's, because those are not things independent providers are easily have access to.
Yep. And we had representation right in the work group across some of those settings. And I think the goal is to have enough of these best practices that can apply in some of these different aspects. I want to be cognizant of time. Another question that was submitted is around AI, not surprisingly. And the question is, have either of you all in your institutions used AI, or you are aware of folks that have used AI to help assess risk on actual clinical data?
I'm going to say it's coming. So we certainly are using AI, of course, with the ambient technology for initial documentation. And I know that there are different organizations that are looking into AI for, of course, coding, documentation, reporting. And it speaks to, again, that earlier question about burnout. I do think you're going to see that increasingly a bunch of this is going to be automated. Now, the question is going to be, where's the human in the loop verifying if there's a question about whether or not it's accurate. So at the end of the day, whether you're a medical group, whether you're a payer, or the government, you're going to need to be able to verify if the numbers that you're getting don't make sense. And so, or reconciliation, right? So if one entity's concluding or denying something, what's the appeal process for that? So I would say the answer is if it hasn't already started at your institution or with your practice, it's coming and it's going to be here. And the question is going to be, how do you manage that going forward, where it's effective and actually streamlines the work, but doesn't derail the value-based arrangement that you have?
Yeah, I agree completely, Steve. not much to add. I mean, we have various tools that we use, from humans to AI driven tools, to find things in the record that physicians may want to address. Some of the biggest challenges we have is getting them to address it. So we have programs that go in and offer up opportunities for physicians to address specific conditions, and getting them to address more than about 30% of them has not been so necessarily easy. But I agree with Steve. Much more sophisticated tools are coming and will be great, because physicians don't see that as value added, and it doesn't require a lot of clinical decision making, and so it's not necessarily a great use of their time. And the more we do that to physicians, the less they feel the kind of joy that they deserve in their practice, in particular in primary care. And that's something that I think we're very cognizant of.
Absolutely. So I know we're starting to run up on time, maybe throwing out one last question before we adjourn. So we have a question specifically around what best data sources should be used to assess risks. Should it be coded diagnoses, procedure data, clinical EHR data? What do you all think, if it's singular or multiple kind of data sources, to be able to really kind of assess the risk for the population?
So I'll give you my biased answer, and then I'll give you what's the reality out there. I mean, ultimately, if you've got accurate information being recorded in the electronic health record, ideally you pull it from there. I know that, I'll speak for the organization I work for. We, from a care delivery perspective, from a performance improvement perspective, we're not just using coded data. We're actually using direct from the EHR. Now, that's because we're lucky to have a relatively integrated model. Now, if you don't have that, then you do have to rely on coding to at least get at the information. And then that's where it requires reconciliation between the payer and the medical group to make sure that the coding is accurate and reconciled. So, there's sort of, I think, a path to getting towards, more pulling of the information directly from the EHR, but we're not there yet as an industry.
Yeah, and I would say the way I would answer that is, the more information you have about the population you serve, the better assessment of the disease burden and prevalence of illness that you will have, and or the better ability to predict disease. And I'm not sure if that was the question, but so as an example, we have a lot of social driver information in our data, but we don't really use it in a way that helps us to identify more vulnerable populations. We use it for outreach and to connect with community-based organizations and so forth. And I think it's helpful in that respect. We certainly have it available for physicians, and we've done so many different screenings. But if we could have everything from, and some people say your zip code is your best predictor of what the likelihood is of your future health is. If we could incorporate as many of those things as possible, it would be better. Having said that, there are some currently where all we have is age and gender, and that's our risk adjustment. And so the reality is, there's data available that could provide for us a much better assessment of our population's healthcare needs than what we're using right now. And we're, I think, also in the early stages of being able to incorporate that into some sort of financial model.
Fantastic. Well, I want to thank you both again for taking time out of your busy schedules to talk with us and speak from your expertise and your work from your organizations. It's been fantastic. Just want to note for those folks tuned in that on your screen, there's a feedback survey. We really appreciate you all filling those out. Responses help guide upcoming programming to deliver webinars you want to see, such as the ones you saw today. Today was the second part of a 5-part series we have on value-based care this year. Throughout this series, we will be covering other key topics, including data sharing and behavioral health. We'd love to have you back for our next webinar on July 8th as we continue our conversation on these underlying payment methods, this time focusing on the remaining key domains that we mentioned, including levels of financial risk, payment timing, and accuracy. Scan this QR code to register for the entire series. We would love to have you back here for more. And finally, if you are looking for something more interactive, we would like to invite you all to attend our upcoming Saving Time Practice Innovation Bootcamp hosted here in Chicago this September. This 2-day in-person bootcamp is specifically designed for clinical and operational change agents looking to eliminate unnecessary work and free up more time to focus on patient care. If you have interest in attending, scan the code on your screen right now. And for additional resources and guidance to support physicians and staff, including those on payment methodologies, as well as other topics within value-based care, please visit the American Medical Association website or stepsforward.org. Thank you so much for joining us today, and we hope to see you again real soon.